In this video, we'll learn about visual acuity testing. This is one of the very important skills that you have to know, and it is also the most important thing that we do for every patient that walks in. So, what is visual acuity? Visual acuity is the ability of a spatial resolution of the eye. So what do you mean by that? It's like if you have two objects, to your eye's ability to see them as two different objects, or to appreciate the objects in your visual field is called as spatial resolution of the eye. Now, what is the resolution of the eye, or what is the visual threshold or minimum angle of resolution? So we need to know that to understand the visual acuity. So if we have two objects in the visual field, now these two objects to be seen as two distinct objects must stimulate the cones such that they spare one cone in between. So they have to stimulate alternate cones with one cone in between unstimulated. Only if this happens, then these 2 points in our visual field will be seen as two distinct points, objects. If they stimulate this adjacent cones, then the brain perceives it as one single object. So two objects are identified as two distinct objects only if they stimulate cones with one cone in between them unstimulated. Now each cone is around 2 micron in size. Okay, that is the diameter of each cone, and which is equal to 25 second of an arc. So if you approximate it, I mean it's like 50 second is equal to approximately equal to 1 minute. So if you have the objects are forming images which is 50 seconds apart, then that is equal to 1 minute, only then you can see them as two distinct objects. So this is 1 minute is the minimum angle of resolution or the visual threshold of the eye. Now, this is what we test in Snellen's visual acuity, or be it in 2-point discrimination where you're checking the macular function. This is the principle. So, Snellen's visual acuity principle is as follows. So, if you have the angle, if the object is forming an angle of 1 minute at the nodal point, then if you know the distance, if I keep the distance as 6 meters, then we can calculate using the formula tan theta, we can identify the length of the object, right? So if I have to see this letter E as E, I have to identify, please understand this, I have to identify this part, this black part, the white part. I have to see them differently. I have to see them distinctly. Then there's a black part, white and black. So there are 5 parts which I have to see distinctly to identify the letter C. If they're not, if it is less than that, then what will happen? It will the E will appear smudged and I will not be able to identify E. So each letter in a Snellen's visual acuity chart actually forms a one whole letter forms an angle of 5 minutes at the nodal point, but each part of the letter forms an angle of 1 minute. So that is the visual threshold. Okay, so based on this, so how is the Snellen's visual chart formed? How did they come to the size? How did it determine the size of each letter? That was based on, so you keep the angle fixed 5 minutes here, then you keep the distance 6 meters, 9 meters, 12 meters, 18 meters, and you can measure, you can come up with the size of the chart. Now, why did we keep? Now, two things that you have to know is why was 5 meters, 5 minutes kept as the for each this one? Because they could fit most of the letters in a 5 minutes. If they kept it as 5 minutes, they could fit most of the letters. Okay. If they kept only 3 minutes, only few letters could be fit into the chart. That's why they kept as 5 minutes. And why 6 meters is kept? Because beyond 6 meters and beyond, parallel rays of light enter the eye. So that's why you wanted to have letters. The distance was kept at 6 meters and not closer than that. Okay. So these two things you have to remember. Now, how do you do? So this is the Snellen's vision chart. So this letter A, which is marked as 60, at 60 meters in a normal person, this letter will cast an angle of 5 minutes. Okay, so these two letters at 36 meters will cast an angle of 5 minutes. So the same thing. So in a normal person, these letters will cast an angle of 6 meters, 5 minutes at 6 meters. So how do you represent vision chart, distant vision, visual acuity? We have something called 6 by 60 or 6 by 6, whatever it is. The numerator, that is 6, the first numerator, is the distance at which the patient reads the chart. Denominator is the distance at which a normal person can read the letter. So if the patient has 660, a normal person can read this letter as 60 meters, but this person can read this only at 6 meters. So vision is reduced. So what is a normal vision? Normal vision is 6. Normal person can read at a distance of 6 meters. Our patient can also read the same letters at 6 meters. So that is a normal vision. Okay, if it's anything less, it is impaired. If it is below 618, it is visual impairment. Okay, so this is how you represent vision in a norm using a Snellen's visual acuity chart. Now, how is the procedure? The patient is seated at 6 meters or 20 feet. The Americans use feet system. We use a metric system. From the chart has to be illuminated, or examination is done in illuminated room with the chart. If it is the chart is not illuminated, then the minimum recommended illumination is 85 candelas. Okay, that should be the minimum. Or if it is a self-illuminated chart, it has to be that much. So, so you understand, it's at the highest contrast that we check the visual acuity. One eye is examined at a time. Patient is asked to close one eye, left eye, and read with the right eye, and then asked to close the right eye and you check the left eye separate. Individually, you separate check it. Patient is asked to read the chart from 6 meters. The last line that the patient reads is recorded as his visual acuity. If he reads the last line, it is recorded 6.6. Then above 6.9, depending upon whatever number is written, we read it. If he reads some of the lines, but he doesn't read the last line, then we go on to do the pinhole test. Okay, that will come in later. What if he doesn't read the first line itself, first letter itself? Then what we do is we ask the patient to step forward. From 6 meters, he'll step forward to 5 meters, 1 meter forward. Then we'll ask him to read the first line, first letter. If he doesn't read there also, we ask him to move forward by 1 more meter. That's how we check. So when the numerator is changing, the denominator will not change. Please don't write 5 meters. Now he read three lines, so it is 5 by 24. No, you shouldn't write that. If he doesn't read the first line, you ask him to move forward. Now the denominator does not change, and only the numerator changes. But what if he doesn't read at 1 by 6, 1 meter also, he doesn't read the line? Then what we do, then the examiner places his fingers in front of the patient and asks him to count fingers. So if he does that, if he's able to count the examiner's fingers, we call it as counting fingers close to face. If he's not able to do that also, then we do hand movements. So you just wave your hands in front of the patient's eye and ask him if he appreciates the hand movements. If he appreciates hand movements, you will write it as hand movements plus or hand movements positive. If he's not able to do that also, then we do something called as perception of light and projection of rays. Okay, so we just throw a light on the here. It should be a dim room and the brightest light. Okay, so we in a dim room we close one eye and of the patient and project light onto his pupil and ask him if he perceives light. If he perceives light, we write it as perception of light present. Once you do that, then you do projection of rays. So projection of rays is you will use a pen torch and you will put it from all 4 directions: superior, temporal, inferior, and nasal. Right? And this time you'll ask him from which direction he is seeing the light. Okay. So in perception of light, you ask the patient, is he perceiving light or no? Okay, that's it. In projection of rays, you'll ask him from which direction he's seeing the light. That means the patient has to tell you, I see it coming from above, below, or to the left or to the right. So he's identifying the direction of from where the light is coming. Perception of light checks the central retinal function. Projection of rays or PR checks the peripheral retinal function. Okay. So again, uh, PL and PR? You represent it as, if it is PL, if he perceives light, you write it as PL positive. If he does not perceive, you write it as PL negative. If he's PL positive, then you have to do PR, projection of rays, and this is how you represent projection of rays. You put a cross, and you would have thrown light from all the four quadrants. Now if you have thrown from superior and he perceives, you will put it as plus. Okay, you'll put it for plus in all four quadrants. If in a particular quadrant is not appreciated, in that quadrant you will put it as minus. Now all students, you have to remember, if a patient has vision of counting fingers 1 meter and better, please don't do PL and PR. Only if the patient has a vision of hand movements and less, only then you will do perception of light and projection of rays. If a patient has 6-6 vision, you don't have to do perception of light. If a patient has 6-6, we can see you bringing the torch. He doesn't have to, perceive light to tell you that he can perceive light, right? So only if the vision is less than hand movements, only then you will do perception of light and projection of rays. Now, I told you that if the patient saw a few lines but was not able to read the last line, then what we do? We document it as 618 and we go on to do pinhole test. What is this pinhole? It's a 1 millimeter hole, and this is kept in front of the eye, and the patient is now asked to read the Snellen's chart again. So all of you might remember that any lens, the central line through which it passes, if the ray of light passes through the nodal point or the principal axis, it does not undergo any refraction and it passes straight, right? So this is the principle that we are using in the pinhole test. So if the patient had a refractive error, it will form a circular blur, on the retina. But if you prevent the peripheral rays from entering the retina and you allow only the central ray to enter the eye, then it will not undergo any refraction and the patient will start seeing better. So what are the two things? So in the pinhole, you put a pinhole, patient was reading 660 or 624. He was not reading 66. Now you put a pinhole in front of the patient, and if the vision improves to 66, then what is your inference? Your inference is vision is reduced due to refractive error. So if you do refraction, if you give him glasses, the vision will improve. Okay. If the vision does not improve on pinhole test, okay, it was 660, it remains 60, then probably there is a opacity in the visual axis which is not allowing the ray to go through. So a central corneal opacity or a central lenticular opacity, or ray passes through all this and this fovea is not functioning properly, like in macular degenerations or macular dysfunction, then the patient will not see. Okay, so where will you see? If the vision does not improve, then you're probably thinking of a corneal opacity, lenticular opacity, or a macular disorder. Okay. So vision does not stop with only checking the distant vision. You have to check, of course, you have to check both right eye and left eye and document it. And you have to do the near vision testing. Near vision testing is to check the near visual acuity. The near vision charts, the most commonly used ones are the Snellen's near visual acuity chart and Jaguar's near visual acuity chart. So it can be in any language, and you'll have multiple lines. You will ask the patient to read from the largest letters to the smallest letter, and whichever line he reads, you will document the vision as N36, N18, N12, N10, N8, or N6. Okay. In case of Jaguar's chart, it is written as J1 to J7. So again, you have to test each individual eye separately and document the near vision chart, near vision acuity. Now, the patient is made to sit in a well-lit room and each eye is tested separately. You will give the chart to the patient and ask him to hold the card at a distance that he would hold the near objects. Now, this might vary for each individual. Okay, some of them might keep it very close. Some watchmakers might require a very close near working distance. Some of them keep it at a distance and see. So you will ask the patient whatever position he is comfortable, and for that you will correct. Okay. And the patient is asked to read the lines from biggest to smallest lines, and near visual acuity is recorded as the smallest line that the patient sees. So once you have done both distant vision acuity and near visual acuity, you will document it for each eye separately. Right eye distance vision uncorrected. Okay, left eye distance vision uncorrected. Pinhole, if there is improvement in pinhole or no improvement, you will document it. If the patient is wearing spectacles, first you will do without spectacles and then with spectacles. And last thing, you will do the near vision. This is how you document and present the visual acuity. And you need to know the principle of Snellen's vision testing, and what is minimum angle of resolution or visual threshold when you're presenting. Thank you very much.